become extinct. And believe me, there are operations like that in the history of surgery. And we're going to talk more about long-term results of all of these in a minute. So basically, the catheter has to go into the opening. Then there's the access segment. That's the passageway through the abdominal wall. So depending on how thin or not you are, you measure about how many inches that is. The valve is 2 inches. So the catheter has to go in the thickness of your abdominal wall, the length of the valve, and a little bit more, so all the holes at the tip of the catheter are in your pouch. So the catheter goes in about 5–6 inches. It automatically starts draining once it's in the pouch because of the physics of siphoning. But fortunately, since the human body is not like a car, if you siphon gas out of your car, you have to suck on the end of the hose to get it started, which will not be appealing to too many people. But because we're created with positive intra-abdominal pressure, so as soon as the catheter goes in, the material starts draining. You don't have to strain or push. That's not a good way to empty a pouch. It just drains automatically. Now, cramping is always an issue with a continent pouch in the early stages because the pouch starts with a capacity of 4 ounces or so, like 100, 120, 150 cc's. It'll end up having a capacity of anywhere from 500 to 1,200 cc's. I've actually seen patients with a pouch that has a huge capacity they empty once or twice a day because it holds so much. So in the beginning phases, as your pouch is expanding, you're going to have cramping. You could have gastroenteritis. We'll talk about pouchitis in a minute. But basically, the way a continent ileostomy matures is by increasing the interval between intubating. So for the first week, once things are healed and your indwelling tube is removed, we have people catheterized every 2 hours for the first week, from morning till nighttime and 2 a.m. And then they graduate to another week of every 3 hours and hopefully start sleeping through the night. Then a week of every 4 hours. And then every week you try and add a little bit of time to prolong the interval, 4¼ 4½, 5 hours, with the key being you're continuing to eat normal. Because if people think, well, if I don't eat, I won't make gas, I won't make waste, I'll have to empty less, but then your pouch won't ever develop. And you won't be healthy either. So it's all predicated on eating normally. So I tell everyone with a new pouch, it's not like being a teenager all over again, but you're going to have growing pains. And growing pains is you're more aware of gas, you're more aware of kind of crampiness. And some people need some mild medications, some Levsin or Donatol, just to get through those first weeks as the pouch is expanding. Mature pouch, 400 to 500 cc's is a moderate capacity pouch. A small would be 350 or so, but many pouches are much larger than 500 cc's. And it depends a little bit on what people tolerate in terms of whether they are getting any cramping in those early weeks or months, and also on variations in intestines. Some people have intestine that's very small, they have a lot of it, but it's very small caliber. Others have intestines larger caliber, it may stretch and enlarge more. But no matter how small the pouch is to begin with, it will expand if you follow the schedule. Now, anyone who's had surgery can get a bowel obstruction. And I had a patient who was 101 in the hospital last week. She had a hysterectomy when she was 40, and she had a bowel obstruction. She was 101. Fortunately, we got her through it without an operation. But any patient who's had abdominal surgery can have adhesions and can get a bowel obstruction. Fortunately, it's the minority of people that have bowel obstructions. The majority of people, no matter what internal surgery they've had, will live out their life without ever having an obstruction. So we have to differentiate obstruction from growing pains or pouchitis, because pouchitis causes cramps as well. Now, what if the stoma starts leaking? If gas or waste comes out of the stoma, that means something's not normal, because it's not supposed to work that way with a continent ileostomy. And sometimes the pouch can be inflamed. Pouchitis is an inflammation of the pouch. It affects about 30 to 40% of people, whether you have an ileoanal J pouch, a BCIR pouch, a Koch pouch, a T pouch. A pouch is a pouch. It's changing the small intestine into a colon, in a sense. So the small intestine is a continuous flow system, and it's not used to storing material, and that's what we're creating here. Pouchitis is readily treatable. We'll talk about that in a minute. So that if you treat it, then you'll stop leaking. It kind of overcomes the valve. But other problems, and we alluded to them, is a slipping of the valve, and I'll have a picture of that in a minute or two, or a fistula through the valve. If a little pinhole develops through the layers of the valve, as the pouch fills, waste can trickle through that and come out of the stoma. So those kinds of problems lead to reoperations and revisions. I think we talked about this a little bit. Pouchitis, as I mentioned, 60 to 70 people, 60 to 70% of people will never know what pouchitis is. And despite all the research that's been done and all we know about treating pouchitis, we don't know the cause of pouchitis, and we don't really know we know how to treat it, but not necessarily how to cure it. But the good news is 90% of people with pouchitis have an occasional episode. And you go on Flagyl, clindamycin, Cipro, the mesalamine, for people who have chronic recurring pouchitis, which is a few percent, where it's kind of like having colitis in your pouch. And so some of the medications we use to treat that are similar to colitis medications. Mesalamine is Rolasa. So here we would use irrigation. We would put a suppository in the stoma. Or Asacol or Pentasa, those medications. Steroids, question mark. If a patient has a pouch and they've struggled for years with chronic pouchitis and they have just tremendous problems, my recommendation usually is have your pouch removed, make your peace with having a conventional ileostomy. You can live to 110 and have a long and wonderful, happy life. But going on steroids to preserve a pouch, long-term steroids, I don't think is compatible with good long-term health, because we all know that steroids have lots of side effects that affect us indefinitely. Short course sometimes is effective, but that's just my personal opinion. Sometimes people have trouble getting their tube in, and you have to be able to get your tube in. So if you're traveling, you're a tourist someplace, and you have all your catheters in your car, and then you come back and your car is no longer where you parked it, it's stolen, well, you have an issue. You can't evacuate waste or gas. So the first thing to do is not go to a great restaurant and have a big meal. The first thing to do is go to any emergency room. Any emergency room in the world will have Foley catheters, bladder catheters for catheterizing urine. They come in small sizes for urine, and they come in bigger sizes for all kinds of purposes. So most hospitals will not have the specialized catheters that people use for continent ileostomies. Medina catheters, Marlin, the old Mentor catheter, the 30 French silicone catheters. Many hospitals will not even know what you're talking about. But you show them your stoma, you explain what you've had, that you don't have your catheters, you get a urinary type catheter that's similar in size, and you're good to go. There are different techniques to use if there's resistance, and typically that occurs during an episode of pouchitis because things get swollen, and that can make it somewhat more difficult to get the tube in. Normal intubation, lubricants. There is natural mucus coming from the stoma. It's the same mucus in your mouth. And some people have enough that they just put the tube in without any lubricant. Certainly we don't recommend that for a very early healing pouch, but as time goes by, mineral oil, KY, just wet it with tap water. Some people will lick their finger, use the saliva on their finger to rub on the tip of their catheter to moisten it and slip it in. I don't recommend licking the catheter directly. So this is a survey of about 500 patients, and it shows you what the range is of how many times people intubate. Once in 24 hours, I don't recommend that for good health, but some people have been doing that for years, and we don't argue with success. But most you'll see is 3, 4, or 5. If you're intubating 6 or more times, you should talk to your surgeon or doctor managing you, because you might have kind of a smoldering pouchitis that you're not fully aware of, and you go on some antibiotic and you realize suddenly you're intubating only 3 times a day. It's no longer 6 or 7 or 8. There's usually a reason when it's that frequent. So here's a valve that slipped, and without going back in my slides, you recognize the difference is not a straight passageway, it's curved. The valve has unraveled. So it becomes difficult to get a tube through those curves, and waste leaks out. So a patient with a slip valve will need a revision, and we'll talk about revision rates in a minute. And here's an example of a pouch fistula Where waste tends to seep out along a prior surgical incision or where a drain used to be, that's the natural tissue planes where leakage will come.